permission, I'm starting with today's live now. So, greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clearnit, serving as the allocated session assistant to ensure a seamless experience. Clearnit proudly stands as India's most relied upon digital platform, offering a multitude of imaging services exclusively for doctors. It is with great pride that Clearnit serves as a digital partner for this event. And the focus of today's session is USGRA Abdominal Wall Blocks. And now, I would like to invite Dr.AL Meenakshi Sundaram, sir, our distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council member, President and State Secretary of the ISA Tamil Nadu State Branch. Now, sir, we can proceed the session. Over to you, sir.
Thank you. I request our President, Dr. Munian, to offer his presidential address.
Good evening all, I am Dr. K. Munian, ISI President, Puthukkottai City Branch. On behalf of ISI City Branch, Puthukkottai, I welcome the moderator, faculties and our academic chairman and delegates for the online webinar. Every week we are conducting online webinar in the name of Puthukkottai Bhudhan. Today we are conducting 27th episode of second edition of Puthukkottai Bhudhan. Today we are going to talk about the ultrasound guided regional anesthesia for abdominal wall surgery. Ultrasound guided regional anesthesia for abdominal wall blocks has a revolutionized pain management for various surgical procedures in the abdominal cavity. What are the benefits of ultrasound guided regional anesthesia? It provides excellent effective analgesia, reduced hospital stay, and shorter hospital stay, and reduced opioid consumption and improved patient's outcome. What are the types of abdominal blocks? Transverse abdominal spleen block, otherwise called a TAB block. It provides analgesia for the lower abdominal surgery. The local anesthesia will be deposited between the transverse abdominal muscle and the internal oblique muscles. The another one is a subcostal oblique ultrasound guided blocks. The needle insertion between the xiphoid process, it provides effective analgesia. The another one is ilioinguinal and iliohypogastric blocks, which provides excellent anesthesia for hernia and lower abdominal surgery. Already we have discussed already about the superficial structures and the low frequency curvilinear probes for the deeper structures. What are the clinical applications? Post-operative pain management for the lower abdominal surgeries and chronic pain relief for the conditions of the abdominal wall pain syndrome, analysis for the cesarean delivery and other obstetric procedures. What are the key considerations in the ultrasound guided nerve blocks? Proper patient selection and block techniques are essential for the successful outcomes. Ultrasound guidance provides block success rates and reduces the complications. Today, our speakers are interested to share their experience in the various topics like abdominal innervations and anterior blocks and posterior blocks. Okay, we posterior blocks. Okay, sir. Thank you, sir.
Thank you, Dr. Munian. And now I request our secretary, Dr. Kannan, to offer his secretary report.
Good evening all. I am Dr. Kannan, Secretary, ISA Puthukkottai City Branch. Successfully, we are conducting 27th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is ultrasound guided regional anesthesia, abdominal wall blocks. Our president has elaborated the topic. We have conducted 26th webinar on 16th July 2025. The topic was interpretation of ECG. We have divided the topic into 3 subtopics. First subtopic, basics in ECG, was done by Dr. Sudeshna Singha, resident, Bangalore Medical College and Research Institute, Bangalore. Second subtopic, brady arrhythmias, was done by Dr. Madhu KP, Assistant Professor, Bangalore Medical College and Research Institute. And third subtopic, tachyarrhythmias, was done by Dr. Bindu, Assistant Professor, Bangalore Medical College and Research Institute. Our moderator was Dr. Bhaskara B, Associate Professor, Bangalore Medical College and Research Institute. Around 750 delegates have attended our webinar. And one more thing, our academic chairman, Dr.AL Meenakshi Sundaram sir, is going to contest in ISA President-elect 2025. All anesthesiologists kindly support him. He is a very good administrator and academic person. Kindly support him. Thank you, sir. Thank you all.
Thank you, Dr. Kannan, City Branch Secretary of Puthukkottai. Now it is my duty to introduce the faculty to the delegates. So this time it is the 27th webinar and we have crossed the halfway mark. We have intended to conduct 52 weekly webinars, that is continuously for a year. So last week we have conducted the 26th and now we have come to 27. So 50% we have achieved and we have crossed, and this time Tamil Nadu and Puducherry are participating. So the youngest faculty of today is Dr.Emilin. So she is a second year postgraduate and she is doing her post graduation in Mahatma Gandhi Medical College. Actually, whenever we need a person as a human resource personnel, I used to engage Dr. Parsardi. So I called him, and once he picks up a person, definitely they will be of some standard. So we welcome our youngest faculty, Dr. Emilin, and it will be followed. It will be followed by Dr. Nandhini. Dr. Nandhini is known to Puthukkottai people because even though she's an assistant professor, even in this age, she has demonstrated her skill in Puthukkottai CME, physical CME. She has attended and she was a workshop faculty for ultrasound guided nerve block. So that workshop went on very well, and Madam Nandhini is one of the faculty for that. And people used to say PT Usha is a golden girl of India, but the golden girl of anesthesia is Dr. Nandhini. Because I don't know how many gold medals she has secured, and gold price is also increasing. So I think she will become a millionaire by this gold medal earnings. So she's a gold medalist in PG university exam, and she has done her ultrasound guided workshop. That is, everybody is doing now fellow. They call it as FIGRA. So it is a popular degree nowadays, like DM. Everyone is doing that, and she has done it in Mahatma Gandhi Medical College. And see, even in that fellowship, she has secured a gold medal. So another gold medal she secured, and now she is working as an assistant professor over there. So she has years to come to dominate the anesthesia society, and she is interested in regional anesthesia, and she is interested in research and publication. Actually, as an assistant professor, she has published 10 papers. Actually, they need only 2 to be promoted as associate professor, but she has published already 10. Well, way ahead. And even in that, she was awarded the best poster in AORA. In Mumbai Academy of Regional Anesthesia Conference, her paper was awarded as a best poster. And not with stopping with this, she is reading novels. I don't know when she will have time to read novels when she is securing many gold medals. Probably for novel reading also, she will get a gold medal soon. And she is interested in painting. That is mandala art, we used to say. So she is interested in painting. I don't know what exactly she will do in the house. Only these extracurricular activities she will be doing. And the best part is she is interested in swimming. So I used to say that swimming is just like anesthesiology. But this swimming, she has won the championship in junior category and again a gold medal winner in under junior. So even in extracurricular activity, if she wins the gold medal, where other people will go, I don't know. So we people have to take a gold medal only from her and not from anywhere else. So I wish her all the very best. And she will be followed by Dr. Swetha. Swetha is an associate professor in Chettinad Hospital and Research Institute. So she has done her MD anesthesia in 2019. So private institutions, the advantage is she has finished MD in 2019 and immediately she has become an associate professor. That is a great thing within 6 years. And madam is a well-known faculty in ultrasound guided nerve block workshops, and she is interested naturally in chronic pain and regional anesthesia. Actually, she will not give pain to anyone. We have to verify with this Chettinad hospital, but she is interested in pain relief. And again, her hobby is also swimming and reading books. As I said, anesthesiology, why I compared it as swimming. Swimming, there are so many techniques: butterfly, breaststroke, backstroke, formal, so many things. But whatever it is, the idea is to reach the other shore safely. Same way, anesthesia, it is regional anesthesia, ultrasound guided regional anesthesia, or plain regional anesthesia. Then whether it could be GA, whatever it is, you have to reach the shore safely. And we have now two swimmers. I want to see how these two people are swimming. One is a gold medalist, another is going to be a gold medalist in swimming, but she has become associate, so she didn't have the time. So these trio ladies, anesthesiology is replaced by ladies everywhere. Strong chunk after OG pediatrics, anesthesia has become. So these three faculty will be moderated by the great person, Dr. Lenin Babu. We fondly called him as Lenin. See, he is the HOD of the prestigious institute, JIPMER, Puducherry. So whenever we say JIPMER, we have some reputation. Even I appeared for the entrance exam to join MBBS in JIPMER, and even I could not understand the questions. So as a +2 boy, I could not understand the entrance exam questions. And in that prestigious institute, Dr. Lenin is the HOD, and Lenin did his MD in All India Institute of Medical Sciences. That is the reason why he is in JIPMER. So usually this PGI Chandigarh, AIIMS Delhi, and JIPMER are popular institutes, and he is graduated from AIIMS, and he is working in Puducherry. So he is a DIPNB graduate also. Even university exams may be easy, but he has cleared DIPNB and the IDRA exam, and he is presently the professor and head of the department in JIPMER. In addition to that, he is an office bearer because he is a past president of ISA Puducherry. And when he was the president, I had delivered the oration in Puducherry conference. And he has several international and national publications we cannot enumerate because routinely he is doing that. And see, he is the best reviewer award he has won in Indian Journal of Anesthesia in 2018. And more than that, when the Critical Care Society has formulated guidelines for admission and discharge criteria in ICU, Dr. Lenin is one of the members, so we are very happy. I can talk to a member in Tamil, that is an advantage. And naturally, this person is only reading, so he is only intelligent, so his game is also chess. He is interested in playing chess. I am also a university chess champion and participated in All India Inter-University twice. So people like us only play like this, not swimming and all. So we will not spend any energy in extracurricular activities. We will play only chess. I don't know how many calories will be burnt in playing chess. And he is interested in music also. So as an anesthesiologist, he is interested in regional anesthesia, pain medicine, and transplant anesthesia. So we are having a great person in the name of Dr. Lenin, moderator, supported by three special lady anesthesiology graduates and a postgraduate. Now I hand over the session to Dr. Lenin. Please, Dr. Lenin, take over.
Hello, very good evening, sir. And thank you very much for the kind introduction, sir. And I would like to share that I was an intern when you were the assistant professor in Tanjavur that time. And I still fondly remember we had one difficult case, and you asked me to go to the car and then get the something. He told me, go and get this thing from my car back seat. I went and took it there, and then it was a CVP line. With a single attempt, he put the line and then showed me how to do the CVP line in a sick patient, in an obstetric patient. And he was just an academician and very well updated with the knowledge for almost so many decades. And we are very happy to be under your leadership, sir. And I wish you all the very best for the upcoming election, sir. And this, hello.
Audible, please proceed.
Yes, sir. Sir. And regarding the today's topic, so it's a very simple one, and starting from a very basic level of blocks, those anybody can practice. So even somebody has seen once, they can very well do it. That way, starting from that, we can move on to a very advanced blocks where you need to practice and then observe and then assist for some time, and then you can do it. Like that, we have several from the basic to the advanced level blocks are there. So in that aspect, first we'll see what is the basic about the abdominal innervations, and then we'll move on to the several blocks. Okay, can I invite first, sir, will you introduce the speaker, sir?
I have done already. So,
fine, okay,
so
now we'll move on to, we'll invite Dr.Emilin Reni, postgraduate from Mahatma Gandhi Medical College, and let us hear from her about the abdominal innervation. Over to you, Dr. Emily, please.
Yes.
Dr. Emilin?
Yes, sir. One second.
Yeah. Oh, fine. As she is updating her slides, I request all the participants, whatever the doubts you have, please put it there in the chat box. And the only way to we can improve ourselves is by asking more questions. Okay. So it is for you to understand, and many people, they may be having that questions in mind, but they may not be asking for that. So please, whatever the doubt, even it might looks very silly, but that's okay. Please put that questions there in the chat box, and we'll try to, I hope there will not be any need to ask questions, but still everything will be covered in this topic. But still, anything, if you feel that the presentation didn't cover it, or you have any doubt, please just put it there in the chat box. We'll try to answer that.
Here I want to add one thing. The people can ask the questions and put it in the chat box, which will be visible only to the ClearNet organizers. So this platform people will post it in our Zoom platform. It will be visible, but they need not answer the questions then and there, because it will not be seen by the participants. So only verbally they have to reply. So at the end of all the 3 lectures, verbally they can reply according to the moderator's choice.
Yes, sir. Yes, sir. Yes, sir.
Hello, sir. Sir, I was not the question.
We are not able to see the slides, madam.
Dr. Lenin, I think you can proceed with that other person, because there is a hitch. Dr. could not share the screen. That's what we
Okay.
wanted to verify by 5:40, but she entered only late. So I think the next speaker can proceed because we will go by time.
Fine. Okay, sir. And then we'll
She
so
can
we'll go ahead
join
with
she can join as a second speaker.
yes, sir. Then we'll go on because this abdominal innovation everybody knows it, but we wanted to just refresh anatomy. We can always refresh it a bit later. Let us go ahead with the Dr. Nandhini. She is going to speak on about the anterior blocks, and we'll hear from her. Dr. Nandhini, please.
Yes, sir. Sir,
Go ahead, ma'am.
yes, sir. Sir, is my screen visible, sir?
No,
Not
ma'am.
yet,
No,
ma'am.
ma'am.
Can you please share it?
So, ma'am, if you are seeing that it's already been shared, so please stop sharing your screen once and reshare it again.
Just a minute. I'm not able to share my screen because Reni is still sharing hers.
Reni, you have to stop sharing the screen. Dr. Reni, you stop sharing. Because only one at a time.
Can you change the host from side, Mr. Ms. Shwatika? Can you do it from your end?
I think it is not possible. I think it is not possible. Swastika, can you do that?
Yes, sir.
You please
Mr.
stop this.
Ms. Shwatika, can you make Dr. Nandhini as a host?
No, sir. Actually, we don't have that permission. I can make her the co-host only.
Um,
But how that is slide sharing has to be stopped.
There is no issues with slide sharing if there is any host or anything, because everyone in this meeting room can share their screen, sir.
okay, we'll do one thing. Dr. Reni, can you log out from the thing? Automatically, somebody else will become a host. Maybe you can rejoin again.
Okay, sir. I'll leave. One second.
Yeah, please. Dr. Nandhini, can you try now?
Dr. Nandhini, you are sharing the
Yes,
screen?
sir. Sir, is it visible, sir?
No, it is
Because
not.
I just a minute, sir. I just got logged out of it, out of the.
So now you are seen, you have to share the screen. Or else
1 minute, sir.
is there any platform issue? Dr. Swetha cannot. Now it is coming.
Is it visible, sir?
It is not yet. Share your screen. You are sharing the screen. Click that.
Is it visible, sir?
It has come. Make it as a full screen. Yes, yes, it is visible.
Visible, sir. Is it in the PowerPoint?
No, you have to change the slide. You advance the slide. Yes, it is moving, but you have to enlarge it.
Yes, you can see. Yeah, please carry on.
Shall I carry on, sir?
Yes, yes, yes.
Yes, sir. Very good evening to all the the participants here. At the outset, I would like to thank Meenakshi Sundaram sir for giving me this opportunity to present on an esteemed platform. And I'm also grateful to my professor, Dr. Parthasarathy sir, for referring me. So today I'm going to be talking about anterior abdominal wall blocks. I'll be first starting my presentation with a brief anatomy of the anterior abdominal wall. So the abdominal wall, it is a myofascial structure which extends between the thoracic cage and the pelvic girdle. It is divided into anterolateral and the posterior wall by your posterior axillary line. Now, the anterolateral abdominal wall, what are its boundaries? Superiorly, its boundaries are your costal margins and the xiphoid process of the sternum. Inferiorly, it is by the iliac crest, the inguinal ligament, and the pubic symphysis. In the either side, it is by the posterior axillary line. The contents or the myofascial structures of the anterolateral abdominal wall are your skin, subcutaneous tissue. Then we have the external oblique muscle, internal oblique, transverse abdominis, and the rectus abdominis muscle, which is a paired muscle. And apart from these muscles, their aponeurosis also contributes to the anterolateral abdominal wall. So from the three muscles, that is the external oblique, internal oblique, transverse abdominis, we have their aponeurosis, which forms the linea semilunaris. Then this aponeurosis divides as anterior rectus sheath and posterior rectus sheath and covers the rectus abdominis muscle. Then these two rectus sheaths converge to the center to form the linea alba. Then apart from this aponeurosis, we also have our transversalis fascia and our parietal peritoneum. All these skin, subcutaneous tissue, muscles, the aponeurosis, transversalis fascia, and the parietal peritoneum all together form the contents of our anterior abdominal wall. Now, coming to the innervation of our abdominal wall. The anterolateral abdominal wall is innervated from T6 to T11 thoracoabdominal nerves. Next, we have our subcostal nerve, which is T12, ilioinguinal and iliohypogastric nerve. Now, let us look at the distribution of these nerves. So, from the spinal nerve, the dorsal, we have our dorsal rami and a ventral rami. The dorsal rami supplies the skin and the paraspinal muscles, whereas the ventral rami travels in a plane between the internal oblique and transverse abdominis, and at the level of mid-axillary line, it gives a lateral cutaneous branch. Then the ventral rami further travels in the same plane, that is between the internal oblique and transverse abdominis, enters the rectus abdominis muscle, that is a plane between the rectus abdominis and posterior rectus sheath. Then it travels through the rectus abdominis muscle and comes anteriorly and gives out the anterior cutaneous branches. Now, if you ask me, does all the thoracoabdominal nerves, that is from T6, T7 to T12 and L1, does they follow the same distribution? No. The upper thoracic nerves, that is the T6 to T9, they enter the tap plane medial to the anterior axillary line. Whereas the lower thoracic nerves, that is the T10 to L1, they enter the tap plane, that is the plane between the internal oblique and transverse abdominis, more laterally in a progressive manner. Now, what is the implication to us anesthetists with respect to this type of nerve distribution? When we talk about the tap block, the implication or the importance is because there are two different types of tap blocks. One is the subcostal tap and the other one is the lateral tap. So when we block the nerves using the subcostal tap, we will be blocking the nerves from T6 to T9, whereas at the level of mid-axillary line, when we give a mid-axillary tap block, we will be blocking from T10 to L1 nerves. So this is the first variation with respect to our anterolateral abdominal wall. Next, the second variation. When you talk about the dermatomal distribution, say for example, at the level of umbilicus, it is T10. Does the same thing is followed throughout, or the traditional dermatomal is described? No, because the lower thoracic nerves When they enter the tab block, they form a communicating branches among them at the level of your mid-axillary line. So from this, they give rises to your anterior branches, and these anterior branches pierces the posterior rectus sheath and lie in the rectus sheath plane. That is between the rectus abdominis muscle and your posterior rectus sheath. At this point, these communicating branches again forms a rectus sheath plexus, and these plexus give rises to your anterior cutaneous branches. Now, what is our implication in this? When we talk about the individual nerve, say for example, T10, it also has communicating branches from T11, T12, and maybe L1 also. So if I want to block the T10, that is not possible because it also has communicating branches. So this is the second variation. Now, all the blocks which I am going to be describing are facial plane blocks. Now, what is the difference between the facial plane and your nerve blocks? Sir, hello? Hello?
Hello.
Hello? Ma'am, am I audible?
Yes, ma'am, you're audible.
No, my screen just, is my screen visible?
Yes, visible. Can you please open?
Yeah.
Yes, now it's fine.
Yeah. Sorry for the interruption. So what is the difference between the nerve block and a facial plane block? When it comes to nerve block, we are seeing the nerves, say for example, femoral nerve or supraclavicular approach to the brachial plexus. We are looking at the nerve, we are visualizing it, and then we are depositing the drug around the nerve or the plexus. Whereas in facial plane block, we deposit the drug either between the two fascias or between the muscle or the facial plane. When it comes to nerve block, we can give or we can achieve a surgical anesthesia, whereas facial plane blocks provide only analgesia. In nerve blocks, we can use a lower volume of local anesthetics, whereas facial plane blocks require a higher volume of local anesthetics. Now, when we talk about facial plane blocks, there is a marked variability with respect to the name, anatomical descriptions. When it comes to research and education, it is very difficult to define or identify the individual facial plane blocks. So the two regional anesthesia societies, that is your American Regional Anesthesia Society and your European Society, together have did a Delphi consensus study on abdominal wall blocks, where they tried to standardize the nomenclature with respect to name and their anatomical description, such that the same name will be used henceforth in all researches and educational purposes. The name, it indicates the name of the block, whereas the anatomical description is nothing but the anatomical placement of the needle tip. Now, with respect to our abdominal wall blocks, what is the recent or the standardized nomenclature? The rectus sheath, ilioinguinal iliohypogastric, the subcostal tap, all these three have the same name. The previously what they were called, the same nomenclature is being followed. Special mention is to lateral tap and mid-axillary transverse abdominis plane tap. So these two blocks are now called as mid-axillary tap block. Similarly, once what was called as posterior tap block previously, and now it is called as the lateral quadratus lumborum block. Now, moving on to our abdominal wall blocks. In the anterolateral wall, I'm going to be talking about 4 blocks. One is the rectus sheath, second the tap, subcostal tap, ilioinguinal and iliohypogastric plane block. So before you perform any block, what are the prerequisites? First, we should get an informed and written consent. We have to confirm the correct side of the block, that is especially with respect to ilioinguinal and iliohypogastric. Always stop before you block. Ensure aseptic precautions. Do not exceed the toxic dose of the LA, especially with respect to facial plane blocks where we will be using a higher volume of drug. So always calculate the maximum dose of local anesthetic for that particular patient based on his body weight and then proceed with the block. Ensure intralipid 20% is always present inside the OT complex. So the blocks such as rectus sheath, tap, ilioinguinal, iliohypogastric, and subcostal tap, I will be explaining in the following headings, that is anatomy, patient position, probe selection, ergonomics, sonoanatomy, needling, and its clinical applications. Now, the first block, that is the rectus sheath block. The anatomy of rectus sheath. The rectus abdominis muscle is present in the midline. It is covered by your anterior rectus sheath and posterior rectus sheath. The anterior rectus sheath is formed by the aponeurosis of external oblique and internal oblique, whereas your posterior rectus sheath is formed by the aponeurosis of internal oblique and transverse abdominis. Together, they cover the rectus abdominis muscle. Now, as I told before, this is the rectus abdominis muscle. You have an anterior rectus sheath and posterior rectus sheath. When we describe the rectus abdominis, the rectus sheath block, it is commonly termed as a tram track appearance. That is, you see two lines in the below. So what are these two lines? The first line, what we see is the posterior rectus sheath, whereas the second line, what we appreciate as tram track appearance, the second line is nothing but your transversalis fascia and the parietal peritoneum. Now, when you, as we know, at the level of T10 or below the level of T10 or at the line of the arcuate line, the posterior rectus sheath is deficient as depicted in this picture. You can see the rectus sheath here, whereas below the level of arcuate line, the rectus sheath is deficient. So this particular block, that is the rectus sheath block, is contraindicated when you are planning to put it below the level of T10 because posterior rectus sheath is deficient. We will be injuring or entering directly into the parietal peritoneum. So this is a picture where the posterior rectus sheath is deficient and we are seeing only the peritoneum directly below. Now, what is the patient position? Position is going to be supine. We will be using a linear probe. Why we are using a linear probe? Because it is a superficial structure, so a high frequency linear probe can be used. Next, coming to ergonomics. So this is my chief professor, Dr. Swetha sir, under whom I did my fellowship in regional anesthesia. So whenever sir comes into the OT, he will always emphasize on the ergonomics. Why ergonomics is important? If I say it just like how my chief sir or my mentor would say, it is when you have a good ergonomics or an appropriate ergonomics for that particular block, the comfort of the performer is very high. And then your block or your procedure will flow without any resistance. Now, if I ask sir, what is a good or an appropriate ergonomics? He will always say performer, patient, and the USG machine has to be in a straight line. So moving on with our sonoanatomy of the rectus abdominis muscle, we start scanning from the midline. We see the linea alba here. Then as we move laterally, we are able to appreciate the rectus abdominis muscle. On top, we are able to see the anterior rectus sheath. Below, we see the posterior rectus sheath as a tram track appearance. That is two lines. So the first line is nothing but your posterior rectus sheath. The second line is formed by your transversalis fascia and your parietal peritoneum. So our target is between the rectus abdominis muscle and the posterior rectus sheath. Moving on to needling, how we are going to do needling trajectory is going to be in plane. We will be going from lateral to medial. Here you can see the needle entering from lateral to medial. We are placing the needle tip, or my target is to place the needle in between my rectus abdominis muscle and my posterior rectus sheath. I am injecting a volume of 20 ml of local anesthetics. So here you can see a very good unzippering or a peeling off of the muscle from the fascia. So this indicates that I am in the correct plane and I am not in the intramuscular. So volume is going to be 20 ml of local anesthetics. Again, the choice of local anesthetics is a performer's choice. You can use bupivacaine, lignocaine, or bupivacaine. Now coming to the clinical applications. This particular block, that is your rectus sheath block, blocks only the anterior cutaneous branching. So it provides somatic analgesia in the midline. So it can be used for umbilical hernia cases and midline laparotomies where without epidural placement is contraindicated. One word of caution, the epidural vessels may be in the epidural vessels are usually present in the rectus abdominis muscle. So your needle trajectory has to be careful such that you don't injure these vessels. Again, to re-emphasize, at the level of arcuate line or below the level of T10, the posterior rectus sheath is deficient. So this block is contraindicated if you are planning to do it below the level of umbilicus. Moving on to my second block, this is a tab block. This is a very simple, most commonly performed facial plane blocks. It is technically very easy. There are no major structures or vital structures in the view. So anatomy, from the top, we see skin, subcutaneous tissue. We are seeing the 2 or 3 muscles, that is your external oblique, internal oblique, and transverse abdominis. Our aim is to deposit the drug between the internal oblique and transverse abdominis. Again, patient position is going to be supine. I'll be using a linear probe or the high frequency probe because it is a very superficial structure. Ergonomics, performer, patient, and the US generation has to be in a straight line. Moving on to the sono anatomy, we start scanning from the midline. I'm placing my probe transversely in the middle. I'm seeing the linea alba, and then I'm looking at the rectus abdominis muscle. As I come laterally, I'm looking at the linea semilunaris. Then my 3 muscles of interest, that is external oblique, internal oblique, and transverse abdominis, comes into my view. My target would be to deposit the local anesthetic between the internal oblique and transverse abdominis muscle. So needling again, you can do it in plane or out of plane. Always in plane is preferred. So needle is coming from posterior, anterior to posterior. And my area of interest or my target is to path my needle between the internal oblique and transverse abdominis. Again, I'm giving a 20 ml of local anesthetics as this point. Tab blocks are always bilateral, so you have to give it bilaterally. Here we can see the unzippering of the facial tissue from the fascia. Again, the volume is 20 ml. Local anesthetic is performer's choice. Clinical applications. So this covers from T10 to T12. It also covers ilioinguinal and iliohypogastric nerves. So both anterior and lateral cutaneous branches are covered. So this tab block, the mid-axillary tab block, is used for lower abdominal surgeries or preferred for lower abdominal surgeries. It provides only somatic analgesia. It does not take care of the visceral analgesia. Moving on to the third block, that is the subcostal tab block. Anatomy, from the skin, we have the skin subcutaneous tissue. The target interest or the place where I have to give my subcostal block is between the rectus abdominis muscle and the transverse abdominis muscle. This is the plane where I have to inject my local anesthetic. Patient position, again supine. It is a superficial block, so I'm using a linear probe. Again, ergonomics is the same. Performer, patient, and the ultrasound machine to be in a straight line. So now anatomy of the subcostal tab block. So from the midline, I am seeing the linea alba here. So as I move laterally, I'm able to visualize my rectus abdominis muscle. Some more, if I go obliquely along the costal margin, I'm able to see my transverse abdominis muscle in view. As I move more obliquely towards the costal margin, the linea semilunaris comes into view. And more, and if I go laterally, I'm able to visualize the 3 muscles, that is your external oblique, internal oblique, and transverse abdominis. So my area of interest or my target for subcostal nerve block is going to be between my rectus abdominis muscle and my transverse abdominis muscle. So my needle is coming in plane from medial to lateral, and I'm parking my needle here, and I'm injecting 20 ml of local anesthetics at this plane. We can see a good unzippering or a peeling off, which indicates that I am in the correct plane. Now, again, local anesthetic volume is 20 ml, and the local anesthetic of choice is performer's choice. Clinical applications. It covers the dermatome of T6 to T9. So it is used for majorly for upper abdominal surgeries. If you combine this subcostal tab with your tab block, also called as a 4-quadrant tab block, then it can give somatic analgesia for major abdominal surgeries. Again, as I told, it provides only somatic analgesia. So the last block is ilioinguinal and iliohypogastric nerve block, which I'm going to be discussing. Anatomy, the iliohypogastric nerve, that is T12 nerve root, whereas your ilioinguinal nerve is from the lumbar plexus, that is L1. So these nerves, they travel in front of the quadratus lumborum muscle and they enter the tap plane, that is between your internal oblique and transverse abdominis. Patient position, probe, and the ergonomics is the same as my previous block. So sonar anatomy, I'm placing the probe transversely over the iliac crest. I'm visualizing the iliac crest in one side, and on the other side, I'm visualizing the three muscles, that is the external oblique, internal oblique, and transverse abdominis. And in the plane between your internal oblique and transverse abdominis, I'm able to visualize the ilioinguinal and iliohypogastric nerve. So my target would be to deposit it, local anesthetic, in this plane. In this plane, 20 ml of local anesthetic to be deposited. I don't have a needling video for this block. Now, what are its clinical applications? Volume is again 15 to 20 ml. What are its clinical applications? Iliohypogastric nerve innervates the skin below the subcostal nerve, whereas your ilioinguinal nerve innervates the skin and soft tissue over your inguinal ligament. So it is used for inguinal hernia surgeries and for LSCS, where it takes care of the incisional pain. So in those cases, we can give ilioinguinal iliohypogastric nerve block. Again, the deep circumflex iliac artery always accompanies these two nerves. It also serves as a landmark, but a word of caution, we should be careful because this will be along with the nerve in the same plane, that is between your internal oblique and transverse abdominis. We should not injure the vessel while doing our needling. So we should be careful. Again, there are publications where they have reported anatomical variation. Instead of these two nerves being in the plane between your internal oblique and transverse abdominis, it can be in the plane between your external oblique and your internal oblique as well. So next, coming to one topic, that is additives. I have told about 20 ml of local anesthetics you can use. So what are all the additives you can use with facial plane blocks? So there are studies or literature says that you can use dexamethasone, dexmedetomidine, and epinephrine in your facial plane blocks. So what are these studies saying? When you add dexamethasone to, here in this study, they have added dexamethasone to bupivacaine on a tab block for abdominal hysterectomies. They found that the 24 hours opioid consumption was less. And they found that it was, the analgesic effect was much more prolonged. Similarly, there is one more study where they have compared perineural dexamethasone in vector sheath block versus intravenous dexamethasone. They found that perineural dexamethasone has a better analgesic effect than your intravenous dexamethasone. So you can use additives with respect to your facial plane blocks. Next, one important note about the facial plane blocks: continuous catheters. Can we place catheters in these superficial plane blocks? Yes, you can place. There are studies or literature or researchers, they have placed the catheters in all the three blocks, that is your tap, subcostal tap, and your rectus sheath block. With respect to rectus sheath block, you can place it ultrasound guided, or you can even do a surgical incision of these catheters. But what is the outcome of these catheters? Did they prolong the duration of anesthesia? If you ask, the literature has a very contradicting way, where few studies have claimed that there are, with the catheters, their opioid consumption was less. Whereas in few catheters, the opioid consumption was pretty much the same with and without the catheter. So the continuous catheter is again performer's choice. The literature has a very contradicting view. Now, moving on to the complications. What complications can we expect with respect to our facial plane blocks? The first one is local anesthetic systemic toxicity. Why? Because we are giving it bilaterally, we are using a higher volume. And literature says the last, that is the incidence of local anesthetic systemic toxicity, is higher with facial plane blocks when you compare with your nerve blocks. So the incidence is higher. Second, there can be LA-induced myotoxicity. That is when you inject a larger volume of local anesthetic intramuscular instead of the facial plane, it can cause myotoxicity. So the take-home message from my presentation: superficial plane blocks, that is all the abdominal plane blocks such as your TAP, your subcostal TAP, and your rectus sheath block provides only somatic analgesia. It does not take care of your visceral analgesia. So if your visceral analgesic component is higher, the option would be to go for a neuraxial technique such as your epidural. Always calculate the local anesthetic maximum dose based on the particular patient's body weight before you start the block. Stop before you block, confirm the site, and then proceed with the block. Be mindful of local anesthetic systemic toxicity. And the fifth important point is that all these blocks are superficial blocks. So they can be administered even in patients on antithrombotics. Again, to emphasize, these superficial plane blocks are part of a multimodal analgesia. Individually, these facial plane blocks may not give that much of analgesia, but when combined with a multimodal, it gives a better analgesic effect. Thank you.
Thank you, madam. It was very nice presentation. You have covered anatomy, indications, additives, and the complications and catheters, and across all the areas. That's good.
Thank you, sir.
I hope all the participants will be very clear about the things. And if at all, if they want to ask some questions, please to let them put it in the chat box. We'll answer it at the end of all the 3 lectures. So shall we move on to the third one? I'll invite Dr. Swetha, Associate Professor, and to talk on the posterolateral block. Over to you, Dr. Swetha.
Thank you, sir. Good evening. Is my screen visible, sir?
Yes, ma'am. You are good to go, please.
Okay, sir. Good evening, everyone. I'm Dr. Swetha. At the outset, I would like to thank the organizing team, Dr. Meenakshi Sundaram, sir, for giving me this opportunity. And the topic that I will be presenting on today is posterolateral abdominal wall blocks. So the main focus of my presentation today will be 3 blocks: erectus spinae plane block, quadratus lumborum block, and transversalis facial plane block. So these 3 blocks, if you look at the year they have been described, is actually relatively a newer set of blocks. And all of them are described by performing under ultrasound guidance. And all these 3 blocks are actually facial plane block. Okay. So like already Dr. Nandhini described, a facial plane block is when 20 to 30 ml of local anesthetic is deposited into a plane between facial layers that surround the muscle. The goal of the facial plane block is to block the nerves that travel within this plane. It provides only analgesia. It is important to note that it does not provide surgical anesthesia. So the mechanism of action of facial plane block is the local anesthetic directly contacts the nerve that travels in that plane, and also travel of the local anesthetic to neuraxis like paravertebral space or epidural space, and also diffusion of local anesthetic between the facial layers towards the nerve. And there may be some intravascular absorption as well. This is the overview of my presentation. I'll quickly review the anatomy and what are the structures that we are targeting, how to perform these 3 blocks, and the specific block-related complications, if any. So this is the abdominal wall showing the innervation and dermatomes. We already know that abdominal wall is supplied, innervated by T6 to L1 spinal nerves. Out of these, T6 to T11 spinal nerves, they will travel in the intercostal space, their respective intercostal space, and exit the intercostal space to lie within the tap plane, that is between the internal oblique and transversus abdominis muscle. Whereas these two nerves, T12 or subcostal nerve and L1 spinal nerve alone have a different fate. So let's look at the course of the T12 and L1 spinal nerves. So this is the cross section of the abdominal wall. You can see the rectus abdominis muscle. Laterally, you can see the three muscles, internal oblique, external oblique, and transversus abdominis. And this is the lumbar vertebrae with the transverse process. At the tip of the transverse process, you can see a quadrilateral muscle, that is the quadratus lumborum. Anteriorly sitting on the vertebral body is the psoas muscle, and posteriorly there is erectus spinae muscle. So these spinal nerves T12 and L1 will exit the neuroforamina and travel through the psoas muscle and come to lie anterior to the quadratus lumborum, pierce this blue line. This blue line below the transversus abdominis is actually transversalis fascia. It pierces the transversalis fascia and come to lie in the tap plane, that is between the internal oblique and the transversus abdominis muscle. And the dorsal rami is given off posteriorly. It travels over the transverse process and pierces the erectus spinae muscle, supplies the posterior 1/3 of the muscle. And the ventral rami, it will give off a lateral cutaneous branch in the mid-axillary line. And this is the sympathetic chain branch. Depending on the course of this these spinal nerves, we look at the locations of various blocks. When the local anesthetic is deposited between the erectus spinae and the transverse process, in this location, it is erectus spinae plane block. And there are 3 to 4 variations for the quadratus lumborum blocks, depending on the location of the local anesthetic deposition. If we deposit the local anesthetic in the lateral portion of the quadratus lumborum, it is QL1 block. If we deposit the local anesthetic posterior to the QL, it is QL2 block or posterior QL. And when the local anesthetic is deposited anterior to the QL, it is QL3 or transmuscular QL. And one more less commonly described block is intramuscular QL or QL4, which is rarely performed. And one of the newer blocks is the TFP block or transversalis facial plane block. You can see the blue line representing the transversalis fascia. When the local anesthetic is deposited below this transversalis fascia, it is the TFP block. You can see that the TFP block is very close anatomically to the QL1. There is hardly any place between these two blocks. Coming to the erectus spinae plane block, erectus spinae is a group of muscles that run along the axis of the spine. So the erectus spinae group is located posterior to the transverse process, and you can see the dorsal rami piercing through the erectus spinae and supplying the posterior 1/3 of the abdominal wall. When the needle is inserted and made contact with the transverse process and local anesthetic is deposited between the transverse process and erectus spinae, this block is erectus spinae block. And the mechanism of action of this block is when it directly blocks the dorsal rami and there is an anterior spread to the epidural paravertebral space anteriorly, and also there is some amount of drug reaching the psoas compartment where lumbar plexus is located. And also there is a lateral spread where the lateral cutaneous nerve is blocked as well, giving us lateral analgesia of the abdominal wall. And also there will be craniocaudal spread, giving us multiple level analgesia when we perform erector spinae block. If you look at this cross section, you can see the articular process and the transverse process. The transverse process must be 2 to 3 centimeters in length. You can see the dorsal rami crossing this transverse process in the medial portion, not at the tip, before it branches to medial, intermediate, and lateral branches. So it is wise to give the injection in the medial part of the transverse process rather than in the tip of the transverse process. Also, when you give the injection in the medial part of the transverse process, the spread to the ventral rami and also to the psoas compartment is higher. The chances of spread is very higher. So we'll see how to differentiate this medial portion of the transverse process from the tip of the transverse process. When we place the probe transversely across the transverse process, this is the image we'll get. The ultrasound beam passes through the vertebrae and we'll see the cat ear-like appearance of the articular process and the flat hyperechoic line of the transverse process. In the ultrasound image, the cat ear-like appearance of the articular process and the flat hyperechoic line on either side is the transverse process. Our aim is to deposit the drug in the medial portion close to the articular process. So in the longitudinal view, when the probe is placed parasagittally, you can see the transverse process as finger-like projection. Now we need to differentiate whether this is the tip of the transverse process or medial portion of the transverse process. So when the probe is placed over the tip of the transverse process and you move the probe, you can see the finger-like projection, that is the transverse process. When you move the probe laterally from the tip, you can see that the transverse process disappears. This is how, this disappearance is how we'll know that we are at the tip of the transverse process. But when you move the probe medially, you can see the transverse process appearing and transitioning into hump-like articular process. So this is the articular process. And from here, if you move immediately medially, this portion is where you need to place your needle to get a good analgesia from an ESP block. So this is the needle that is between the erector spinae and transverse process. This is where the local anesthetic deposition should happen. So ESP block is a block with fewer complications. It is technically very easy. A beginner also can perform this very safely, and it can be even performed on patients who are on anticoagulants. Unlike epidural, it will not cause any hypotension, and it provides good and consistent analgesia over the posterolateral abdominal wall, and depending on the volume given, it can even spread anteriorly to the epidural space and give visceral analgesia as well. A 30 ml of injection given on one side, depending on thoracic or lumbar level, it can provide 8 thoracic level analgesia and 4 lumbar level analgesia. This is about the erector spinae block. Moving on to the second block, that is the quadratus lumborum block. It is also a facial plane block that is performed in the posterior abdomen, and it provides good analgesia for abdominal surgery and hip surgeries as well. And it also provides visceral analgesia. The mechanism, we'll look into the mechanism a little later. If you divide the abdomen into upper half and lower half, we know that the blocks like paravertebral, ESP, rectus sheath, and subcostal will provide good analgesia for upper abdomen. And blocks like paravertebral, ESP, rectus sheath, and posterior tab, depending on the level we perform, gives a good analgesia for the lower abdomen. But quadratus lumborum actually claims to provide very extensive analgesia, that is from the level of T4 to L2 with single injection. So like we already saw, posteriorly we have the erector spinae. At the tip of the transverse process, laterally we have the quadratus lumborum, and anteriorly we have the psoas. To do the quadratus lumborum block with the classic shamrock leaf appearance, we'll place the curvilinear probe over the lateral abdomen. And this is the image we would get. This is the transverse process, and this is the L4 vertebra. This sort of looks like a thumbs up appearance. And at the tip of the transverse process, we can see the quadratus lumborum muscle. And posterior to the transverse process, you can see the erectus spinae muscle. And anteriorly, we can see the psoas major muscle. These three form the shamrock sign. So posteriorly, we have the erectus spinae muscle, laterally quadratus lumborum, and anteriorly psoas muscle. The shamrock stem is formed by the transverse process, and the three muscle, psoas, QL, and ESP, erectus spinae, forms the leaves of the shamrock. So for easy identification, this transverse process along with the vertebral body looks like a chair, and the psoas muscle sits on the chair. That is how we identify the psoas major muscle. And the QL muscle is always hypoechoic in nature compared to the other muscles. It is slightly hypoechoic. And the block location of various QL blocks would be a lateral or the QL1 is lateral to the quadratus lumborum, and posteriorly would be the QL2 or posterior QL and transmuscular QL between the QL and psoas major muscle. To understand the mechanism of action of quadratus lumborum block, we need to know the anatomy of the thoracolumbar fascia. So this thoracolumbar fascia has got three layers. Anterior and posterior to the quadratus lumborum, we have anterior layer of the thoracolumbar fascia and middle layer of the thoracolumbar fascia. And the layer covering the erectus spinae posteriorly will be the posterior layer. So these three layers are in continuation with the transversalis fascia in the lateral side. So this middle layer along with the posterior layer forms a triangle that is called the lift, lumbar interfacial triangle. This triangle is very important because you can see this is the abdominal branch of the lumbar artery traveling through this triangle. This is where we perform the QL block. So we should be mindful of this artery to avoid injury to this artery and causing a hematoma. Also, imagine this lift, that is the lumbar interfacial triangle, as a three-dimensional triangle that runs craniocaudally. And because of this only, when we inject the drug in this plane, we get a good craniocaudal spread of the local anesthetic, providing such extensive analgesia. So this is an alternative view to perform the quadratus lumborum block. When you place the high frequency linear probe over the lateral portion of the abdomen, you can see that three muscles of the anterior abdominal wall, external oblique, internal oblique, and the transverse abdominis. You can see the transversalis fascia going under the transversalis abdominis muscle, and laterally you have the quadratus lumborum muscle. So in this view also we can perform quadratus lumborum block, all three of them. If you deposit the block local anesthetic in the lateral portion of the quadratus lumborum, it will be QL1, and posteriorly it will be QL2, and anteriorly between the quadratus lumborum and psoas major muscle, it will be QL3. So this is an alternative view. So out of these three QLs, QL1, 2, and 3, which QL block should we choose? It depends on the type of surgery. If we are blocking these nerves for lower abdominal surgeries and hip surgeries, we can go for QL1 and QL2, which will give adequate extent from T12 to L2. But if you need good analgesia for upper abdominal surgeries, you have to go for QL block 3 or transmuscular QL, which is closer to the epidural space, neuraxis. So this there will be some amount of visceral pain relief as well. So complications related to quadratus lumborum block, in addition to the regular complications we see with other blocks, the specific quadratus lumborum block related complications will be injury to the abdominal viscera, as the plane of injection, abdominal viscera is close to the point of injection, and there also can be injury to the branch of lumbar artery, and there can be inadvertent spread of local anesthetic to the nerve roots as well. Coming to the third and final block, transversalis facial plane block. This is relatively a newer block. In this, this is the same view that we used for quadratus lumborum block. You can see the external oblique, internal oblique, and the transversus abdominis muscle. Underneath that, you can see the transversalis facial fascia. And the local this portion is the perinephric fat. So when the local anesthetic is deposited below this transversalis fascia, it is the transversalis facial plane block. You can see that this is very close in location to the QL1 block. So this provides very good analgesia for phenensteel incision, iliac crest biopsies, and hernia surgeries, as it will cover the T12 to L1 branches. To perform the block, you can see the high frequency linear probe is placed over the lateral abdomen, and these are the muscles. This is the transversus abdominis muscle and the bulkier internal oblique muscle and the external oblique muscle here. This is the perinephric or the retroperitoneal fat. This moves with respiration. So needle is inserted in plane, and this is the transversalis fascia. So you can see the needle coming in plane, piercing the transversalis fascia. So the first injection that I gave went wrongly above the transversalis fascia. After this, I adjusted the needle, and the local anesthetic is deposited over here. You can see the retroperitoneal fat is being pushed down, and the local anesthetic spread here. So this is the transversalis facial plane block. So with this, I conclude my presentation. To summarize, understanding the plane of local anesthetic injection and mechanism of action is very crucial for block selection and to get maximum out of these blocks. Thank you.
Thank you very much, madam. It was a very good presentation. You illustrated according to the nomenclature, all the blocks, everything told very well. And it was very nice and easy for all the participants to understand it. And one more thing I wanted to convey is that, see, normally whenever we have a complications, we always go back and read. So it's like vice versa. You read and then go back and do the procedure and then come back and refresh it. In that way, so today we are lucky. Nama AL Meenakshi Sundaram sir பாடியில் சொல்லணும்னா எல்லாம் நன்மைக்கே. So today the first lecture we could not do on time. Maybe that will help us to understand the innervation better. Now we have seen the anatomy, everything. Now we'll go back and then refresh our anatomy. So now I'll invite Dr. Reni to do the presentation. Dr. Reni, please go on.
Yes, sir. So I'll be talking about the abdominal innervations. My content of my topic will be innervations in the
you are able to, I mean, we are good to go. Please put the slideshow and then go ahead, madam, please.
Dr. Reni, go to slideshow.
Is it visible?
No, you go to slideshow mode.
Slideshow.
Ma'am, in the upper words, you will get an option as a slideshow, and after clicking on that, you will get the option from the beginning, and after then you can have the full screen, ma'am.
Okay.
In the upper words, you can get the options as a home, insert, design, animations, and then you can have the slideshow, ma'am. Okay, no problem. I've already.
Dr. Reni, can you just go to the top where you can see the
Yes.
insert design animations? No, can you see the slideshow there?
Yes, sir.
Yes, you can click that and then start from the beginning, from
So,
the current slide or from beginning.
Sir?
yes, from
Is it
beginning.
visible? Yes, sir. Is it visible now?
No, from the
Don't ask that.
you have to click the from beginning. You see in the left top, no? Left top, you see the front, come down and then you can see the front from beginning. Can you go to the top? Yeah, come down. You see the front from beginning. Yes, fantastic. Good.
Sir. So the content of my topic will be innovations in the anterolateral abdominal wall and innovations in the
Dr.Emilin,
1 second, sir.
why there is, you just click that from beginning. Second line first.
Yes, sir.
Then resume slideshow.
Is it visible, sir, now?
No, it is not. Right, you proceed. It is not in slideshow mode. You just pass on the slides, let it be like that. That you have to click. No, why you are from, yeah, whatever it is, you click something.
Yes, sir.
So, ma'am, you can do one thing, ma'am. You can stop sharing your screen once and reshare it again, ma'am.
No issues, Reni. You please do this like this because I don't want to miss the lecture. You please go ahead. You please pass on at least.
I think she will take some time to sort out the technical glitch. In the meanwhile, can we take the questions which was there? And
You can.
yes, sir. Fine, sir. And there is an interesting question from Dr. Muthukkottai. How long does analgesia last when facial plane blocks given for LSCS? What is the concentration of local anesthetic is recommended? Can Dr. Nandhini can take it?
Yes, sir. Sir, actually, in our institute, there was a study where we had compared tab block with ilioinguinal and iliohypogastric for lower segment cesarean section. The study was done by Partha sir, Hemant sir, and my mentor, Professor Dr. Swetha sir. So, in that study, what we found was tab block was more efficient for LSAS when comparing with ilioinguinal and iliohypogastric. And tab blocker, the 24 hours rescue analgesic consumption was less. So I'm not able to say how long it will last. And the concentration what we used was 0.25% bupivacaine, sir.
Okay. Yeah, but in addition to that, probably as you mentioned, maybe we can add some additives in addition to the local anesthetic that
Yes,
also definitely prolong the analgesia.
Yes, sir.
Fine. And there is another question. What is the maximum dose of bupivacaine and ropivacaine for analgesia? Dr. Nandhini, please.
Maximum, yes, sir.
Yeah, what is the
The
maximum dose of?
concentration, yes, sir. The concentration for analgesia in bupivacaine would be 0.25%, 0.25% bupivacaine. And with ropivacaine, it is going to be 0.2%, sir. The maximum dose is again the same, 2 mg per kg body weight, and ropivacaine is 3 mg per kg body weight, sir.
Yeah, I think that make it very clear. And there is another question. What needle do we have to select to get sonographic view and feel of the planes?
So we can use a 23 gauge spinal needle because the needle will be very much stiff when we compare it with a 25 gauge spinal needle. So we can pass the needle correctly in the facial plane. That is one. There is no need for using any peripheral nerve stimulator because we are not going to be using a peripheral nerve stimulator in facial plane blocks. That is the second. And third one, when you talk about hypodermic needles, the bevel is going to be little bigger. So we might pierce the fascia and come out. So half the needle will be inside the fascia and half the needle will be outside the fascia. So in my opinion, 23 gauge spinal needle would be a better one. If there is a cutting edge, then that is better, sir.
Yes,
We
correct.
can have the feel of facial plane better.
Exactly. So to have that feel, definitely we need a short bevel needle. Ideally, we could have a sonographic needles, but which is will not be available in all the settings. So to have a balance between the availability of the sonographic needle and the easy availability, maybe we need to balance somewhere in between. In that case, maybe the spinal needle is a reasonable option to have that good feel. I think the remaining questions we'll take up later. I think Dr. Reni is ready. Dr. Reni, come, let's go ahead.
I'm extremely sorry for the interruption, sir. So I'll be talking about the abdominal innervations. So the content of my topic will be innervations in the anterolateral abdominal wall, innervations in the posterior abdominal wall, and some about the abdominal part of the autonomic nervous system. So quick basics of the abdomen. So the picture showing the layers of the abdominal wall, where we have the skin, subcutaneous tissue, which is of two layers, superficial fatty layer, also called as camper fascia, and the deep layer, which is a membranous layer, it is also called as scarpa fascia. And then we have the three flat muscles, which is external oblique muscle, internal oblique muscle, and transversus abdominis muscle. And then we have the transversalis fascia, which is the thin layer lining the transversus abdominis muscle. Then we have the extraperitoneal fat and parietal peritoneum. This is a picture showing the muscles of the anterior abdominal wall. So we have the three flat muscles, which is external oblique muscle, internal oblique muscle, and transverse abdominis. So external oblique muscle, we located in front of the abdomen. When you cut open it, you will see the internal oblique muscle, which is the fibers moves in opposite direction to that of the external oblique. And then when you cut open the internal oblique, we will be able to see the transverse abdominis muscle. And there is a muscle, longer muscle, which is a vertical muscle in front of the abdomen on either side, separated by the linea alba, which is a fibrous band in between, in the midline. This is called rectus abdominis muscle, which is also called a six-pack muscle. And these are the muscles of the back, which I'll be discussing later. So innervations in the anterolateral abdominal wall. So it is innervated mainly by the skin muscles, and the parietal peritoneum of the anterolateral abdominal wall are supplied by the intercostal nerves, which is T7 to T11 thoracic spinal nerves, and T12 spinal nerve, which is also called subcostal nerve, and L1 spinal nerve with its branches, iliohypogastric nerve and ilioinguinal nerve, which originate from the lumbar plexus. So this is a picture showing the intercostal nerve. So the dorsal and ventral root of the spinal cord from the intervertebral foramina, they combine to form the spinal nerve, which gives off two branches, which is dorsal rami and the ventral rami. So this dorsal rami, it contains motor fibers, which supplies the muscles of the deep muscles of the back, and it gives off cutaneous branch, which is lateral branch, and medial branch. Medial branch remains within the muscular layer, whereas the lateral cutaneous branch, it supplies the skin of the back. This dorsal, this is dorsal rami, and another branch is the ventral rami. It is also called as anterior primary rami. This anterior primary rami of the lower 5 intercostal nerves T7 to T11, they emerge from their respective intercostal spaces, and they come to lie in a plane between the internal oblique muscle and transverse abdominis muscle. This plane is called as a transverse abdominis plane. So the nerve travel anteriorly from posterior to anteriorly in the infromedial direction, and it gives off the lateral cutaneous branch at the level of the mid-axillary line. and pierce the posterior lamina of the internal oblique downwards to enter the rectus sheath anteriorly. So it enters the rectus sheath and it pierces the rectus abdominis muscle. As you can see here, it pierces the rectus abdominis muscle and it gives off the anterior cutaneous branches which supplies the skin overlying it. This is the course of the intercostal nerve. Then we have the T12 spinal nerve, which is the subcostal nerve. So this subcostal nerve, it enters the abdomen posteriorly under the arcuate ligament of the diaphragm. So as you can see, the arcuate ligament of the diaphragm, it enters posteriorly and it passes in front of the quadratus lumborum muscle. So this is a quadratus lumborum muscle. It passes in front of the quadratus lumborum muscle and it pierces the transverse abdominis muscle to enter the intermuscular plane, that is transverse abdominis plane between the transverse abdominis muscle and internal oblique muscle. As it enters the plane, it runs along it. And the rest of the course is similar to that of the rest of the thoracolumbar nerves. So it pierces the internal oblique aponeurosis, posterior lamina of the internal oblique aponeurosis, and then it anteriorly enters the rectus sheath, and again it pierces the rectus abdominis muscle and gives off the cutaneous branches to supply the skin overlying it. Then we have the L1 spinal nerve with its branches iliohypogastric and ilioinguinal nerve. So this L1 spinal nerve, it gives off branches iliohypogastric and ilioinguinal nerve in front of the quadratus lumborum muscle. So the iliohypogastric nerve, it emerges from, this is the psoas major muscle and this is the quadratus lumborum muscle. So this iliohypogastric, it emerges at the lateral border of the psoas major and it runs downwards laterally in front of the quadratus lumborum muscle and behind the kidney and colon, and it pierces the transverse abdominis muscle little above the iliac crest and runs in the abdominal wall, supplying the anterolateral muscles of the abdomen. Similarly, the ilioinguinal nerve also takes the same course as it runs in front of the quadratus lumborum muscle and it pierces the transverse abdominis muscle. But slightly at the lower border of the internal oblique, it pierces that it enters the inguinal canal and it supplies the medial and upper aspect of the genitals and thigh, medial aspect of the thigh. So the dermatomes of the anterolateral abdominal wall, so the nerves T7 to T9, they supply the skin from the xiphoid process just above the umbilical region. So T10, it supplies the skin around the umbilicus, and T11 to L1, it supplies just below the umbilicus and up to the pubic region. So innervations in the posterior abdominal wall, we have lumbar plexus and its branches and abdominal part of the autonomic nervous system. So in abdominal part of the ANS, we have sympathetic nerves and parasympathetic nerves. So sympathetic nerves, the thoracic splanchnic nerves, it is of greater, lesser and least thoracic splanchnic nerves, and lumbar splanchnic nerves from the lumbar sympathetic chain. So parasympathetic nerves, it's from the vagus, which has got right and left vagus, and pelvic splanchnic nerves. So lumbar plexus, it is a plexus of nerves on the posterior abdominal wall. So the ventral rami of L1 to L4 upper part makes the lumbar plexus. Lower part of the L4, it combines with the L5 to form the lumbosacral trunk. So it innervates a little part of the lower abdominal wall, but it is more concerned in the supply of the lower limb. So formation and location of the lumbar plexus, here the anterior rami of the L1 to L4, they emerge from the respective intervertebral foramina and they enter the substance of the psoas major muscle and it gives off the branches to the psoas and the quadratus lumborum. After they form the plexus, after this they form plexus within the psoas major muscle. So abdominal part of the ANS, so we have the innervation, sympathetic and parasympathetic, which is extrinsic component. We have the intrinsic component, which is enteric component. So these systems, they coordinate to regulate the GI motility, secretion, sensation, and the blood flow. And it also helpful in maintaining the digestive homeostasis and responding to the physiological demands. So sympathetic innervation. So sympathetic innervation, we have the spinal cord segments and the sympathetic chain. So the sympathetic innervation is the thoracic and the upper lumbar spinal segments T5 to L2. So the sympathetic fibers, they originate from these spinal segments, and it inhibits the GI secretion and motility and contracts the sphincters. So this pathway involves preganglionic sympathetic fibers, and then they synapse in the ganglia, and from the ganglia, the postganglionic fibers arise following the arterial routes and supply to the target organs. So sympathetic pathway, it has got so T5 to T9, they pass the sympathetic fibers originate from the T5 to T9 thoracic spinal nerves, and they pass the sympathetic trunk and they form the greater splanchnic nerve. And this splanchnic nerve, they combine, they pass to the celiac ganglion. So celiac ganglion, where the synapses occur, and from the celiac ganglion, the postsynaptic fiber arises, and they go on to supply the celiac, supply the celiac plexus. From the celiac plexus, they pass on to supply the midgut organs. Similarly, the lesser splanchnic nerve also arise, the sympathetic fibers from the T10 and T11, they arise and pass the sympathetic trunk, and they form the lesser splanchnic nerve, and then they go on to the inferior mesenteric ganglion where the synapses occur, and from that the postsynaptic fibers, they arise and they go to the superior mesenteric plexus around the superior mesenteric artery of the abdominal aorta, and from the plexus they go on to supply the midgut organs. Similarly, the T12 splanchnic nerve also originate from the T12 spinal nerve. The sympathetic fibers, they carry from the T12 spinal nerve, and they go to the inferior mesenteric plexus, and then they via the inferior mesenteric plexus, they supply the midgut organs. Then we have the lumbar splanchnic nerves, which is L1 and L2, L2 segments. They also go on to the inferior mesenteric plexus, and then they supply the hindgut organs. So these are the prevertebral plexus of the abdomen. So this is the celiac trunk. So surrounding the celiac trunk, we will have the celiac ganglion and celiac plexus. And then we have the superior mesenteric artery and superior mesenteric plexus surrounding it. And then inferior mesenteric artery and inferior mesenteric plexus surrounding it. And at the bifurcation of the aorta, we have the superior hypogastric plexus, and around the internal iliac arteries, we have the inferior hypogastric plexus. So through these plexus, it supplies the foregut organs. The foregut organs are stomach, liver, pancreas, and spleen. And through the superior mesenteric plexus, it supplies the midgut organs, which is small intestine and part of colon. And through the inferior mesenteric plexus, the hindgut organs get supplied, which is distal colon and rectum. And the superior hypogastric plexus innervates the pelvic viscera. And these plexus, they contain mixed sympathetic and parasympathetic fibers. So parasympathetic innervation is by the two nerves, vagus nerve and pelvic splanchnic nerves. So this vagus nerve, it supplies the foregut and the midgut. So they originate from the medulla oblongata of the brainstem, and they enter the abdomen through the esophageal hiatus. So they enter through the esophageal hiatus, and they travel to the celiac plexus, and it gives off two branches, anterior trunk and posterior trunk. So the anterior trunk through the celiac plexus, they supply the foregut organs, and the posterior trunk, they run over the celiac plexus, then they join the superior mesenteric plexus, and they supply the midgut organs. So the other component is the enteric component. So an autonomous nervous system of neurons in the wall of the GI tract, we have two plexus. Myenteric plexus, also called as Auerbach plexus, which controls the motility of the GI tract, and submucosal plexus, also called as Meissner's plexus. It regulates the secretion and the local blood flow. So it is modulated both by the sympathetic and parasympathetic system.
Thank you very much, Dr. Reni. It was a very good presentation. And it is important for us to know that apart from the cutaneous innervation, we need to understand about the sympathetic and parasympathetic supply of the organs also, because all these blocks, it will be giving a somatic. All these blocks will give the somatic pain relief. It may not be giving the visceral pain relief. That's why it's important for us to know the entire anatomy. Okay. Thank you, Dr. Reni.
Thank you, sir.
Shall we move on to the question sessions? Okay. There is another question by Dr. Doli Nagarveli. How to assess the block? Dr. Shiva.
Hello.
Yes, ma'am. They want to know how to assess the block. Whatever the block we are giving, how to assess the.
Okay, so all these are facial plane blocks. So they only provide somatic analgesia, and they do not provide anesthesia as such. So assessing the block so much will not be possible, and they have limited visceral pain coverage. So we need to supplement systemic analgesics with along with these blocks.
Yeah, that is true. Maybe once the block is being given, so we know the dermatomal distribution and what are the nerves that just going to be blocked by that particular block. So
Yes.
in that distribution, we can assess whether the effect is there or not. We can identify. That way, we can identify the block is successful or not. But
Yes,
as
sir.
you said, it may not be giving the visceral pain relief. So that part is there is a lack in understanding about that one.
Yes, sir.
And another question: what about the newer block, newer USP blocks? It's posterior block, but much safer and covers the pain of abdominal surgery.
Yes, sir. I don't understand the question, sir.
What they mentioned is, what about the newer block, ESP block? I don't know. Maybe they want to know anything new in the ESP block. Maybe that's what I understand.
Yes, it is a posterior block and it is safer. And depending on the incision, the level of analgesic coverage we want, we can do a segmental ESP. We can achieve a segmental ESP dermatomal coverage.
Yeah. In addition to that, sometimes the anterior nose is not getting blocked because there is unclear mechanism about the mechanism of action about the ESP. That
Yes,
by
sir.
earlier we used to give for even for breast surgery, we used to give the ESP block, but there is some controversial area. Sometimes it works for the anterior cutaneous nerve, sometimes it doesn't. Maybe
Yes.
the science is evolving. We can get more.
Yes, sir.
Yes. So if you have any other questions, we can put it there in the chat box, please.
Sir, these are the all questions we have got, sir.
Yeah, yes. No, I'm just telling you, in case anything more, they can keep updating there in the chat box. So this is all very basic blocks. Like the rectus sheath block is a very basic one, I would say, because when they are going, they need not pierce any structures. They can just go and then stop before the posterior rectus sheath. So practice the rectus sheath block more often. That will give them more confidence to the needling also. And then they can go ahead with the tab block and QL blocks, getting more and more free hands that way. What about your opinion, Dr. Nandhini? Like, how do you want that residents to get trained to start with? What kind of blocks they can perform at the beginning of their career, and then as they gain more and more experience in the ultrasound, they could go for advanced blocks. And what is
Yes,
your
sir. Definitely,
opinion?
sir. Definitely, sir. We can start with basics blocks such as SAB block, where there are no any vital structures. You only see the muscle, and tab block is a very good block to practice the needling as well. You can bring the needle in plane. So tab block and rectus sheath block, as we told, sir, they are very superficial blocks and relatively easier to perform. So if they are a beginner with respect to your ultrasound nerve blocks, they can start with these facial plane blocks and then progress to the individual nerve blocks.
The only thing is the rectus sheath is going to be giving analgesia only for the midline structures.
Midline structures.
So what
Yes,
are the like surgical procedures do you usually perform these blocks, especially
So
the
with
rectus sheath blocks?
So with respect to rectus sheath block, it provides only somatic analgesia in the midline. So you can give it for umbilical hernia surgery, so where the incision is going to be in the midline. Second, it can be given for major laparotomy surgeries. It will take care of the incisional pain only. That is the pain generated from skin and subcutaneous tissue. And though even in laparotomies where the epidural placement is contraindicated, only in that cases we can go ahead with this rectus sheath block, sir.
Okay. In our practice, even for the laparoscopic cholecystectomy, because
Yes.
they put a 10 mm port for the
Port in the
umbilical
midline.
port.
Yes,
Yes.
sir.
And then
In the midline.
yeah. So the mostly the pain, the
Mm.
pain can come from the other two ports also. But
Yes, sir.
the 10 mm ports they'll cut, and then that is relatively that is having the more traumatic port. So we used to give the rectus sheath block bilateral for the 10
Yes,
mm
sir.
port. So, but again, we need to be covered for the other ports also. But that gives us some significant pain relief for
Pain relief.
those kind of surgeries.
Yes, sir.
What about the ESPs, Dr. Swetha?
Yes, sir.
What kind of surgeries do you
Uh,
routinely practice?
Yes, sir. ESP, like you already mentioned, it has got a controversial mechanism. So some say that it provides, it covers the anterior cutaneous nerve. And in cadaver studies, they have shown that ventral rami spread. And only thing is for midline incisions, bilateral ESP catheters has to be placed to give continuous analgesia. And when anticoagulation is there, the it can replace the epidural when the patient is on anticoagulants.
Yeah, yes. Maybe the anteriorly we are like as we told about the rectus sheath block. Maybe the posteriorly the ESP is the one which is very easy to start with. Maybe all the residents can do it with the minimum experience.
Yes, sir.
And can you just highlight about what is the actual controversy about the ESP? Why is that happening?
So the spread to the epidural space and to the ventral rami is not consistent with ESP, sir. Like I mentioned in my presentation, maybe the location of the ESP block that is performed plays a crucial role in it. We have to target in medial portion of the transverse process. Then maybe the spread to the anterior ventral rami is much more consistent.
Yes. But anyway, otherwise also when they start doing for all the like for the discectomy and all the posterior surgeries, when they start performing consistently,
ESP
then
is
they'll be
very
able to do
good
it.
for posterolateral analgesia, sir. All the rib
Yes,
fractures,
exactly.
fractures, posterior surgeries, even PCNL, we can rely on ESP, sir.
Exactly. I think that is the ESP block is a very easier one. So what we used to do is once the patient is positioned, normally we will clean drape and then we'll give the block and then we'll hand it over to the surgeons, right?
Yes, sir.
So what sometimes we do just
Hello.
to clean drape it, and then in the meanwhile we can do the preparation for the uh, like getting covering the probe and then getting the drugs, everything. And then when the surgeon is everything's ready, and then we can give the block so that we can we can save the time. But only thing is we will not be able to give the adequate time for the blood to act before the incision. That is one drawback.
Yes, sir.
Okay. And what about the use of catheters?
Catheters for midline incision, like lumbar discectomy is also midline incision. We need bilateral catheters, sir.
Yes.
Otherwise, bilateral catheters provide adequate analgesia and we can prolong the analgesia. Even in my postgraduate institute, for liver transplants, we used to put bilateral epidural catheters, sir. It worked very well.
Yeah. Yes. Good. The catheter is going to give a long-term pain relief, and then this is consistently giving very good analgesia for all the post-lateral innervations. That way it's very good. All right. And how can we improve the training for the residents? Like how can they improve themselves? Is there any model? Is there anything available? How for their understanding? So usually we have that ultrasound simulator is there, where the blue phantom is there, where they can use the needling. They can understand the needling. Once they understand the orientation of the needle and the probe,
Yes,
and then it'll be very easy for them to start with the ESP and rectus sheath block.
yes, sir. All these are easy to perform, sir. They can practice on patients itself.
Exactly. So maybe even they understand the anatomy, and then if they have seen only once, and then they can very well go ahead and do the blocks easily.
Yes.
And another question is there: can QL block and ESP given in patients with anticoagulant?
ESP can be definitely given, sir. It is a more superficial block, and when there is bleeding, you can give compression. But QL, it is not advisable when there is anticoagulation because it is much deeper block, and you cannot compress if there is a bleeding or a hematoma formation. So for QL, it is not advisable. ESP definitely yes. When there is anticoagulation, we can go ahead with ESP, sir.
Yeah, we are more bothered about the hematoma near the site, but here there is no vascular structures. So in that way, we'll be able to give it easily. And then if at all any bleeding is there, we can do the compression. That way, ESP is a better one.
Yes, sir.
Okay, yes, good. All right. Are there any other questions do you have more in the chat box?
Nothing more.
Okay, then shall we move on to for our final comments, sir?
Yeah.
Yes, sir. I think we'll thank all the speakers, and my sincere thanks to Dr.AL, sir, for your consistent effort to spread the academics throughout the India. And I really appreciate that one, sir. And it will be very, he told, so don't quote any studies, trials, review articles. You keep it to the very like kind of practice oriented, which the postgraduate will be able to understand. So he's more concerned about the postgraduates and the practicing clinicians. In that way, all these topics were very focused towards postgraduates and the clinicians. And thank you very much for your report, sir. And then I was very happy to be part of this program. And thank you very much, sir. And over to you, sir.
Thank you. Now I request our treasurer, Dr. Hema, to propose the vote of thanks.
Yes, sir. Good evening, everyone. I thank you all for your presence on the 27th episode on the abdominal wall blocks. Our sincere gratitude to Dr.AL, sir, the man behind the show. I thank Dr.Emilin Reni, postgraduate, Mahatma Gandhi Medical College and Research Institute, Pondicherry. Ma'am, you have given a very detailed presentation. Thank you. I thank Dr. Nandhini, Assistant Professor, Mahatma Gandhi Medical College and Research Institute. Ma'am, you have never failed to impress us. consistently outstanding performance. Thank you, ma'am. I thank Dr.Swetha, Associate Professor, Chettinad Hospital and Research Institute. Ma'am, you have given a very detailed and clear presentation, easy to understand. Thank you, ma'am. I thank our moderator, Dr.E.Lenin Babu, sir, Professor and Head, JIPMER Puducherry. Thank you, sir. Thank you for your support. I thank Clarinet for your continuous support. I thank all the participants, colleagues, and postgraduates for their support. Kindly extend your support to Dr.AL, sir, for the post of President-elect in the upcoming elections in ISA 2025. Thank you. Thank you all.
Thank you, madam. I request the Clarinet to pass the concluding remarks.
Thank you, sir.
Sure, sir. So, thank you so much to all the dignitaries present here. The Clarinet is really thankful for giving us this opportunity to host the session. And I really hope that you all had a seamless experience. So, with all your due permission, we can conclude the session in here for today. And looking forward to host you again.
Thank you.
Thank you so much.
Thank you,
Good
sir.
night.
Thank you. Thank you, sir.
Thank you, sir.
Thank you.
Good night.